But the parents of those patients, they did not believe that they were having pain. Neither the physician believed that they were having pain. One case report was from Germany, a girl who was born without both upper limbs. When she came to school, on the first year of her school at 11 years of age, she could count simple numerical arithmetics with her phantom finger. She could gesticulate. She could say, welcome. She could say, bye-bye. She could move her hands when she is talking. This description was so vivid, so accurate, so definite. But the physician failed to understand that what she was telling was right. Unfortunately, diplomatically, that publication labeled all these children as liars. We thought that they are not telling the truth. The children, they are pretending to be normal like their peers in the school. But subsequently, by the elegant work done by Ronald Meljar, the Nobel laureate who was awarded Nobel for his theory of gate control theory in pain, he has convincingly proved that with several case reports, several investigations, he has convincingly proved that these congenitally aplastic children have phantom limb pain and phantom experiences. Now, question is, what is the next, 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 yes, here. So, now question is, we cannot blame those physicians for not recognizing the phantom limb in congenitally aplastics, because at that time she had in background the concept of body schema. According to body schema, only after birth, from acquired sensory inputs, you construct a template of the body in your brain with long time. And after 10-15 years, if you have amputation of any part of your body, that imprint in brain only may be the mechanism for having a phantom limb pain. But when convincingly it was proved that congenitally aplastics also can have pain, phantom limb pain, that led to the genesis of a new hypothesis of neurometrics and neurosignature. According to this hypothesis, there is an extensive neural network in the brain, starting from thalamus to the cortex, from cortex to the limbic system, from limbic system to the association cortex, and this is innately inherited. This is genetically determined. We failed to understand this previously. And on this genetic background of neurometrics, every day from environment, you are acquiring new information, sensory inputs that is passing through these neurometrics, and this is modulated and upgraded, producing a neurosignature, a body self-image in the brain. And this modulated and upgraded image, body self-image is producing output which is responsible for the pain perception and actions taken by the brain. So this is a dynamic process, neurosignature. This is also not stable. Next. Next. So you can see the neurosignature. After this is determined genetically, and after acquired information, it is modulated and updated and producing the neurosignature and output of pain perception. Now we can explain lot of chronic pain syndromes with this, all this together, the concept of neuroplasticity, starting from peripheral receptor to the human brain. Next. I will mention just few chronic pain syndrome where there is convincing evidence that central sensitization and neuronal reorganization in the cortical level plays in the pathomechanism of these diseases. Phantom limb pain I have already described. Headache, you know, the migraine and tension type headache, there is evidence that the central sensitization and neural plasticity plays an important role in pathomechanism of these two syndromes. That's why the treatment nowadays of migraine, prophylactic treatment, has been targeted using modulating drugs for preventing this disease. Fibromyalgia was a puzzle to the physician and to the patient. Now we understand that fibromyalgia is a basically disease of this neural plasticity, and the treatment, whatever investigation you do, that will only spend money to the patient and all will come as normal. And targeting your treatment according to this new understanding has achieved some success in treating fibromyalgia. Myofascial pain syndrome, temporomandibular dysfunction, osteoarthritis, chronic osteoarthritis patients, some subset of these patients are having neural plasticity. And if you do a total knee replacement in this group of patients, there will be persistent pain, it will be a failure. You have to add some neuromodulating drug in these patients to get relief of pain, persistent pain. Next. To mention few other, the visceral pain syndrome, we know the irritable bowel syndrome and the non-cardiac chest pain, chronic pancreatitis. All these are due to this central sensitization, and treatment now includes medicine which are modulating, either preventing or minimizing this central sensitization. We know of post-traumatic disorder, primary dysmenorrhea, and atypical odontalgia, which is nowadays known as phantom tooth pain or persistent dentoalveolar pain, chronic fetal syndrome. All this and many other chronic pain conditions, if you understand neural plasticity, you can target your investigation to minimize expense and get maximum benefit to the patient. You can target your treatment modalities to achieve better success. Thank you.
Thank you, Subrata, for your nice deliberation. As we are running late, we will move on to the next session and we will discuss it after the session. Okay? We will move on to the next topic, please.
I just want to congratulate Dr. Subrata. When I was doing my MBBS, and we used to consider the best teacher. They used to deliver their lecture without slides, without any papers, and without any transparency. So he has delivered whole of the lecture without slides, and we must appreciate that this was the most complex and most complicated lecture, and he has done very well. Thank you, Dr. Ray. Without wasting time, we will go to the next lecture. It is Dr. Batra. Dr. Batra. This is an opportunity to introduce Dr. Batra. We all know Dr. Batra. He is a professor and head of the Department of Anesthesiology and Critical Care at PGI Chandigarh. I know him personally, very polite, very humble, and always ready to help others. And there must be many all over the country and all over the world whom he has mentored very nicely and very diligently. So I request Dr. Batra to come on the stage and deliver the protocol-based pain management, which is a very important topic and which should be the theme of all over world and all over India, to have a uniform protocol for each and every type of pain management. That is what he is going to explain. Thank you, Dr. Batra, please.
Thank you, chairpersons, and I must congratulate the scientific committee for their excellent scientific program, and which they have included research in the topics. But that after these teaching problems, Dr. Subrata Rai has in fact, off temper, he has spoken about almost 15 minutes. But I was scared that if my slides will not be visible, then it's very difficult to speak for next 15 to 20 minutes. So actually, if you see the scientific program of various Indian scenarios, whether it's pain medicine or in state chapters or in institution level, you will find very little lectures on this aspect. And for this, I compliment Dr. Das. He has written a very excellent editorial which has appeared in Indian Journal of Pain 2015, where he has stressed the role of do we need protocols for pain management in Indian scenario. And briefly he has discussed in one-page editorial about the need of a joint venture of various specialists like pain physicians or orthopedicians, neurologists, neurosurgeons, and physiotherapists. But the problems with the Indian scenario is that we lack infrastructures. At the same time, the research articles, they are in the lower hierarchy. The evidence is not coming as it should have been in the West. So we tend to follow the various protocols which are often used in the West. And in West also there is some difficulty in implementing. And although protocols are useful and they are in fact rigid statements where there is some variation in, you can say little variations in their objectivity. But more importantly is sometimes these protocols are patient friendly and they might help us in medical legal implications. And as we know that in the present setup, our patients are well educated, we have internets, they sometimes understands what is happening as far as pain is concerned and how to go about it. So pain physicians, they have sometimes in a dilemma in order to understand the patient psyche. So I'll be just briefly touching about next 15 minutes. In fact, I'm just touching the basic outline or principle of protocol management. Next slide, please. Now, if we take the ideal protocol, it should be, of course, valid. It should be renewable. It should be repeatable. It should be representative by various specialties. It should be clear, unambiguous, written in English or any local language. Of course, cost effective, particularly in our scenario, because we have less of setup of infrastructures. And more importantly is that it should be amenable and also amenable to the auditing. So these are some of the characteristics of a nice protocol in any situations, whether it's in pain or any other specialties. Next slide, please. And if we know this WHO letter, it has been discussed for the last, I think, more than 40 years. So it is stepped care. This is a protocol which we have followed for years together and even following 3-step ladder, starting from weak analgesics to strong like morphine. It has been also well researched, and more importantly, most of the literature suggests that in about 80% of the patients, they are satisfied with this WHO letter. But recently, in 21st century, there is some legacy about, or some dispute, or some discussion